And welcome back to Endotopic. I'm your host, Romi Mirza, and we are here with Dr. David Kulber. How are you, Dr. Kulber?
Very good, thanks. Thanks for having me.
Excellent. We are having a conversation that's on the cutting edge of surgical techniques.
Yeah.
Yes. Endotopic.
Yes.
Endotopic, baby. Endotopic. Yeah. So how was your week? You doing good?
It's been a pretty good week. Very busy week. It's only Tuesday, and it feels like it was Thursday. So one of those kind of weeks. But with the sea sucker, it always makes things better.
I bet it does. How many cases?
This is cutting edge technology right here.
Oh, okay? Yeah.
Look at this. Yeah.
How many cutting edge technology cases did you do this week?
So far, about like six.
Wow.
It's early. Yeah.
It's early. Yeah. Yeah, exactly.
Early in the week. Only Tuesday. Yeah.
It's only Tuesday. 6 cases already. Look at that. Well, I'm glad we're back. This is our second installment, or is it third, JP? I think it's second. The second installment of our Endotopic podcast. And we're going to today talk about trigger finger, the most exciting of hand surgery procedures.
Yeah.
Well, they're done a lot. Go ahead.
Yeah, no, it's like one of the most annoying hand surgical procedures, both for the surgeon and the patient often, but and probably the most common one, but one that should never be taken for granted.
Why is that?
I think because it really affects the way your hand functions. All your fingers are connected.
Yes.
And if one isn't working correctly, then it's a problem. It affects all the other ones. They're all connected by muscles. So when one finger doesn't work, it affects the other fingers. So if you're having a finger that is triggering, or a thumb,
like this,
that's thumb. Yeah, that's a problem.
Trigger.
Like a little.
There you go.
Little chaka. But, if your thumb isn't working, triggering, that's what separates us from the rest of the animal kingdom. So
yes.
If you don't have a good working thumb, then you're a cat or a dog, and, you can't open up your dog food or fish.
Yeah. So for those of us out there who don't know what trigger finger is, why don't you enlighten us, Dr. Kulber, and tell us what trigger finger is and how you treat it, and then we can go into what we've done to improve it. The treatment, that is.
Yeah, so a trigger finger is when your tendon gets enlarged from just life, flipping people off, whatever you do with your tendon that causes it to go back and forth. And there are many things that we use to go back and forth with, that kind of thing. So you can use your imagination, Romi. I'll let you just...
I do that a lot, actually.
Yeah. Take that where you want to go with it.
Yeah, and, flipping people off, I meant.
Yeah.
Especially when I'm driving.
Yeah.
No, I actually get flipped off a lot when I drive. I don't flip people off. They flip me off a lot.
I'm sure you've been a cause of many a trigger finger.
Many a trigger finger, and probably many of an argument in the car. Did you see that guy?
Yeah. You may have literally caused an epidemic of trigger fingers by the number of people who have had to use their finger to flip you off.
Oh, good. I'm going to keep doing it because we need to sell more endo sleeves.
Yeah, well, yeah.
You like my AM surgical hat? Ooh.
Yeah.
Sporting it right here.
AM trigger finger. Yeah.
The trigger finger and Endotopic brought to you by AM Surgical, manufacturers of fine medical equipment. Just kidding. No, but seriously, the trigger finger. So, what causes it? Is it the pulley? Is it palmar fascia? Is it hereditary? What is the actual cause? That's what people always ask me.
Well, it's a cause of just the way we use our hands in modern society, and people who are predisposed to getting swelling in the hands, like diabetics, people with thyroid disease, they tend to get trigger fingers.
All right, we're back. We had a bit of technical difficulties on our podcast, but we're back. And Dr. Kulber was talking about trigger finger, and we were describing why people get it.
Yeah, and I think we talked about like diabetics or
Mm,
people who get hand swelling, and the tendons swell, and the tendons go through like a series of loops. So I always my analogy is like a fishing rod, and you've got a rod, and then you've got the little loops that the line goes through, and
sure.
you need those little loops because if you didn't have those loops, then the line would just bowstring across the end of the rod, and it
Nice.
wouldn't work, it wouldn't be efficient. So those loops are where your tendon goes
It's
through.
a guide.
And sometimes the tendon gets a little swollen, especially the one in our palm. It's called the A1 pulley, not to be confused with A1 sauce. Right there, yep. And it actually, it's very interesting because you can figure out where your pulleys are based on the Fibonacci sequence.
Really?
Now, do you remember what the Fibonacci sequence is?
I do remember from school.
Remember
Yeah,
Fibonacci?
absolutely.
Yeah.
Fibonacci. Yeah.
Yeah, don't get it confused with Fiorucci, which was like a Gucci knockoff back in the days of the 70s and 80s,
Are you just
where
making stuff up?
no, I'm just they it had wings and it was like a very happening clothing designer,
Really?
Fiorucci. Yep, yeah,
What is it called? Fibinucci?
very Fiorucci. Like
Fiorucci.
I won't leave home without my Fioruccis.
Oh, yeah. No, you
Um,
can't leave home without your
yeah,
Fiorucci's.
but that's Fibonacci.
Is
So
that like Capizio's?
the the hand follows the Fibonacci sequence.
Okay.
Okay.
Yeah.
And what that means is that um, the fingers, the ratio, the Fibonacci sequence is you add the previous number to the next number. So like 0 plus 1, then 3, then 5, then 8, then 11,
Yes.
or actually 12. And you keep adding the previous number to the number that you have. And it
Right.
creates a sequence. Now, the ratio between your proximal phalanx, actually your metacarpal, proximal phalanx, middle phalanx, and distal phalanx follows the Fibonacci sequence. Dr. William Littler, one of the founders of hand surgery, is the person who wrote an article about this. And then that sequence creates the golden angle.
Ooh.
And that golden angle, you can put like an egg in your palm, and if you squeeze it really hard, that egg will not break because it's equal pressure. And then when you
Right.
put your fingers down, they actually point to where the A1 pulley is.
Oh, yeah. Right there.
So that is where your A1 pulley is, right there, where your fingers are pointing. And the
Yes.
A1 pulley is the typical place where your fingers get stuck. The tendons,
The tendon.
which
Right.
are enlarged, they get stuck at the A1 pulley. They can get stuck at the A2 pulley as well, but the A1 pulley is the most common area.
It's like a reverse speed bump.
And yeah, and it's really, so if you think about the Fibonacci sequence, it's a little scary that our hand follows that sequence
It's
because
fascinating.
that sequence is also seen in nature, like in leaves
It's seen
and in other
as well
animals. They all follow the Fibonacci sequence.
in outer space. Absolutely. It's really
So,
interesting.
very interesting point, discovered many years ago, written by Dr. Littler, and it's a repetitive kind of
Yeah.
interesting number.
Yeah.
And it was actually talked about in that movie. The one.
Da Vinci Code.
Yes, you got it. Very well done.
Thank
In the Da
you. Thank
Vinci
you. I
Code, they
tried.
talked about the Fibonacci sequence.
They did. They did.
They,
It was
they,
really cool.
yeah,
You know, I've used many a Littler scissors.
yeah.
I'm sure you
Yes,
do too.
I'm
You have
sure
you have the
yeah.
book in your office, don't you? You've got Littler's book in your
I
office.
do. I do have the Littler book in my office. I
Yes.
could walk over and
I
show it
noticed.
to you
Yeah, and
at the
greens.
end.
I saw it.
Yeah, yeah. We have a lot of books. Yeah,
You have a lot of books. Yeah. Yeah.
a lot of books.
It's a constant learning process being a hand surgeon, that's for sure.
It,
It
it,
never ends. It never ends
no one. Yeah,
for you guys.
there are a lot
Yeah.
of little mechanisms in the hand that you don't really have in other parts of the body that are both functional and mechanic. So to get back to the
Yes.
trigger, to get back to endotopic, the topic
Yes.
endotopic.
I was hoping you were going to get there.
Yeah.
Yes.
The,
So
the,
a trigger
the
finger, if you pull the trigger out like that, it could still trigger
yeah.
again, correct?
Yes, it could get stuck in this position literally.
You get
So
stuck,
your fingers are kind of
extended.
stuck like your hand down.
Right.
Uh, Usually it's stuck with your finger bent and you can't get it back
Hmm.
up.
So then
Uh,
what's the
and
treatment then? What do you prescribe for treatment?
well, initially you could give a cortisone injection,
Right.
and in 50% of the patients that
Every
will
every
work.
doctor's answer for everything. Take some cortisone injection. You'll be fine.
Yeah, it's a miracle drug.
It's
It
a
is a miracle
miracle
drug.
worker. It really is. What else we got?
And but when the miracle doesn't work, then yeah, then there's a surgery to
Yes.
actually open up the tendon sheath
Yeah.
so the tendon can pull through and cure it.
Right. And so
Um,
normally people would make that incision in the palmar fascia, right? In the palm of the hand here. And they would,
that is correct.
yeah, and they would find the A1, cut the A1, not the A2, and then move the tendon and get things rolling again. But you have reversed that, and you've said to me, leaving the palmar fascia alone is the really nice thing to do because whenever you mess with palmar fascia, it doesn't like it. And it's just
Yeah, yeah,
painful. The
yeah.
recovery is horrible. So you were saying to me, why don't we make the incision in the finger crease instead? So if you could elaborate on that, that'd be great.
Yeah, so the palmar fascia, as you alluded to, is literally not your friend.
No.
I think we've talked about that in previous podcast about the endoscopic carpal tunnel,
Mm-hmm.
and the same goes for trigger fingers. That when you violate the palmar fascia, oh, how it can break loose. You're, um, you get a lot of scarring of that area, and you're trading one problem for another, really. And
Interesting.
so it doesn't happen in every patient, but it happens enough that you take a surgery that's fairly simple. You're just making a little incision in the palm, you're cutting a little ligament that takes a couple minutes, and then you're putting some stitches in, and that seems like, oh, you're going to just be fine. Well, it turns out that sometimes you're fine and sometimes you're not, because when you mess with the palmar
Mm.
fascia, sometimes that palmar fascia messes back with you and you get scar tissue, pain, and then you get a contracture. So then you've got like your
Is it
fingers not moving well because it's kind of stuck, but not from the triggering, but from scar tissue around the palmar fascia. And
is
it
it
becomes
like
very,
oh, I'm sorry.
no, you go.
Is it like RSD? The randomness of it?
It's random. I mean, I think RSD is, they're a little more, RSD, you know that like redheads are more prone to RSD.
No
Okay, you
kidding.
know that.
I didn't know
Yeah,
that.
very, very.
Stop it. If
Oh
you're
yeah,
ginger, you're getting
yeah.
RSD.
If I see a redhead come in
Reflex
my
sympathetic
office,
dystrophy, am I correct?
yeah, yes, that is right.
Yeah.
Well, it's now called CRIPS, chronic regional pain syndrome.
Yeah, Crips, right. Chronic
Uh,
regional pain
yeah, that's
syndrome.
a
Yes.
different name for it.
Yes.
But yeah, redheads tend to be a little more. I mean, redheads are
That's
hot,
fascinating.
so
Yeah, yeah, I
um,
agree. I agree.
they're a
They're
little more
always
prone to it.
interesting.
Um, you know, for your palmar fascia, you just have no idea which patient is going to get that inflammation and that pain. But when it happens, it is debilitating,
Mm.
and it's worse than the trigger finger.
So you're
So
rolling you're rolling the dice every time you cut into the palmar fascia. Is what you're saying.
you roll some dice every time. Yeah,
Interesting.
and
So
that's
so by moving the incision into the finger crease, it changes the technique, correct?
yeah, it does. And this really came about, as you know, but we'll rehash the story.
Please.
Is that there's a very busy orthopedic surgeon that I work with at Cedars, and does a lot of hip. He's probably the busiest hip replacement guy around,
Oh yeah.
and he had a trigger finger that for many years I kept injecting to the point where I'm like, okay, if I inject you anymore, you're gonna turn into a steroid, and you may rupture your tendon, and I
Yes.
just don't feel comfortable doing these injections. So you're gonna need to have surgery. And he was like, look, I'm not having anybody make an incision in my palm. That's my money maker right there, where I hold my instruments right in the palm. And I've seen what happens with trigger fingers, that
Yes.
people get scar tissue and pain in their palm. I'm I'm not going to do that. So you figure out a way to do this operation without violating my palm, and we'll do it.
Oh, this is
So
what he was saying. Got it.
that's Yeah, that's what he said to me. So
Yeah.
that's when I said to you, I've got a great idea. Let's figure out how to do this, where we make an incision not in the palm, but like in the crease at the base of the finger where there's no fascia, and
Yes.
people tend to do well when you make incisions there. They don't
Yeah.
get scar tissue there,
Yeah.
and
Exactly.
so
And they're not
it's
holding
like on the
anything
other.
with that part of their hand, right? I mean, in your palm, you're grasping and gripping things, but with the finger crease, it just bends and it actually gets covered by the flesh. So
Correct.
it's very nice. I
It's
mean,
not a
it's
it's
brilliant.
not a contact point. Not a
Right,
contact
right,
point.
exactly. It's not a
Not,
contact
yeah,
point.
there's no
So,
contact.
so then
Yeah.
I came up with a way of doing it endoscopically. Well, not a way, but I came up with a device to do it endoscopically. It's just basically a little tube that slides onto the scope, and it has 2 fingers up and down with a blade in the middle, and then you just get underneath the pulley and go, and you're done. And
That's right. And so
go ahead.
no, go ahead. I'm listening
And
to you.
and I
You're the
and
one.
you know I was using it and teaching it through the palm, and then you were like, no, Rami, don't violate the palmar fascia, like let's do it in the finger. And I was like, for me, and I'm sure for doctors, they're like, wait a minute, how do you find the pulley? That's my first question. Like I always get, they're like, well, if you're not, because when you start in the palm, the A1's right there, it's obvious, but when you start in the finger crease, you're actually on the A2, right? So you have to find the
Yes.
delineation between the two. How do you do that normally?
Well, it's pretty clear. I mean, you see you open up the tendon sheath and you could see the A2. And by the way,
Yeah.
there's many studies showing that you could cut part of the A2. Some people think you could cut all the A2 and you won't
You
get
won't
bow
get the
stringing.
bowstring.
But
Okay.
you definitely can cut most of it. But you don't have to do that here. You just cut into the flexor sheath. You see that where the flexor tendon is, and then you just put the scope in and you dissect a little more proximally and create like a tunnel
Mm-hmm.
underneath the fascia, and then you could see the A1 pulley, and then you deploy the blade. So first I put the camera in to make sure I see where the A1 pulley is, and then I'll put the tube on top of it, and then you just push, and you are able to cut the A1 pulley without damaging the flexor tendons.
And what's the
How do we know that?
benefit of endoscopic versus doing it just with a scissor or Littler? You
Yeah,
like that, huh?
the Littler thing, you threw in the Littler thing, very nice.
Yeah.
Well, one, you're not. The main goal is that you're not violating the palmar fascia, right?
Yes.
So you're not rolling the dice,
And
like
do you
per
shrink
se.
your incision because you're doing it endoscopically?
It's a smaller incision
Okay,
and
that's a
it
benefit.
heals quicker.
Yeah.
It's not healing over the palm, so it's a much easier incision to heal, and it's easier, quicker to do, and plus you can visualize it. So you take pictures because you're using a scope, so
Yes.
you can show the patient. You can show them that you cut their pulley. They can see what you did on them, and it's very easy to photo document, which is nice.
Ooh.
And
Put it in the
and
op
you and
report.
it's much quicker. Yeah,
Yeah, and it's
and much
faster.
quicker.
Faster is great.
Yeah,
If you're gonna have a faster
yeah.
surgery, a faster recovery, and a less uh, healing time for the patient, that's a great thing. Why wouldn't everybody do
Oh,
this?
yeah.
Like
And I mean, more importantly, less scarring.
yes,
Uh,
yes.
yeah.
I mean that's what, and
So
once they leave the OR and they go home, they have to deal with that. The patient has to deal with that scarring. Your job's done. So I mean, if you can limit the amount of pain they're gonna have and scarring, that to me is such a huge benefit just for the patient alone. It's something that
yeah. Well,
we usually don't talk about.
unfortunately, when you make an incision in their palm and they're your patient, you buy them. So they don't just go home and never see you again. They come in on a weekly basis and complain to you every day. My palm hurts. Oi.
My
And
palm, oi, my
and they
palm.
what did you do? I
What are you
thought it
doing
was
to my
just a simple
palm, doctor?
surgery.
What did you do? I don't understand you.
You said it was just a simple surgery, and look,
Yeah.
it hurts. It's pain. I got pain. I got pain. Bolit, bolit. Uh, so and that's a real thing.
Yes.
So I we did a cadaver study on it first to make sure that we got the technique right. We published
Yes.
it
Yes.
just to make sure that we're not damaging the
Where'd you
tendons and
publish
that
that?
we weren't damaging nerves. And what?
What journal is that in?
Oh, the plastic and reconstructive surgery, PRS.
Yes, PRS. Yes.
Yeah. And then we did this cadaver study, and showed proof of concept. So then the next thought was, we'll do it on aliens because we don't care. No. So,
You and Elon Musk, we'll go to Mars and do it on
yeah,
the aliens. It'll be fine.
we went
Trigger
to
finger for everybody.
we went to Area 52 or whatever that area
51,
is,
Area
and we
51, yeah.
51,
They only have 3 fingers,
No,
though, but it's fine.
Yeah,
They still trigger.
What? So
Funny.
after a week in Area 51,
JP went to Area 51 and broke his distal radius, I believe.
That's true. And you guys put one of those 3D printed casts on my.
That's right. Yeah, that thing was cool. Yeah,
Very
expensive,
nice,
but cool.
What was it called? It was called an active armor or something like that.
Active armor. That's right.
Yeah, active armor. Cool. I like it.
Now it looks really cool on my shelf.
Yeah. Thank God. Okay.
Yeah.
That's where you want them.
So yeah, trigger finger. I mean, I get a question a lot about trigger finger is, should you do it endoscopically on the thumb?
No, I mean that because the thumb, when you do it, it's in the crease.
Yeah.
So that's why people don't have a problem with doing trigger thumbs. They don't complain about it. And that was the other reason why I thought, hey, people do great with trigger thumbs. You never have someone coming in complaining about that, but they always come in and complain about anytime you make it in the palm. So that just substantiated my theory and thought was that violating the palmar fascia is no good. Very bad. Very bad.
It's brilliant. I love it. It makes sense, You're connecting
So-
the dots. You're making the conversation on the cutting edge.
So at this
Should I wear it out
point,
more? Yes, sir.
I practiced it a lot and then I finally did that at orthopedic surgeon, and it was great. He went back to work within a week. He actually left the country the day of surgery and went to Florence and hung out and came back like 4 or 5 days later and was operating the following week.
So it was the cheese and the wine, not the surgery that helped.
I think it could have been some of the pasta.
The pasta, cheese,
and,
wine.
Bolognese.
Florence.
Bolognese.
Awesome.
Yeah.
I love
Florence. Bolognese. Yeah.
Bolognese.
Florence.
Valencia.
So
Our terrible
what do you
time.
want? I have a trigger finger. Okay. So
oh my God! All right.
anyways,
yeah. So I mean,
really substantiate that. It's,
I teach it all over the country.
Yeah.
Yeah, I do. I teach it all over the country to doctors after you taught me. That it's not good to go into the palm, and I talk about it, and I could see them in the beginning going, "What is he talking about?" And as I'm explaining it more and more about the recovery and about the patients doing well and the scar tissue, they're like, "Oh, you know what?" And they start seeing the light. They're like, "That makes a lot of sense." And I said, and they go, "Well, why don't I just do it open?" And I said, "Well, you can. It's not. I mean, you can, but the endoscopic is cool and it's interesting and it's a smaller incision, and you get a good reimbursement for it. So why not try it?"
There are a lot of other reasons to do it. Aside from that, one, the access to the finger. If you're you could see if you're triggering at the A2 pulley directly now. And so if you are triggering at the A2 pulley, which happens, then sometimes you need to take a slip of the FDS tendon out. So I think that's an important point of doing that.
Yes.
And then also, if you suspect that they have amyloidosis, you could take a slip of the FDS tendon and send it for Congo Red and save their life.
Yes.
Save their life with the trigger finger.
We're saving lives
Literally.
all the time with our endoscopic procedures.
One trigger finger at a time.
One trigger finger at
Saving
a time.
life.
So another question I wanted to ask you is, when you're doing the procedure, do you get into A0?
You can if you need to. So for the orthopedic surgeon that I did was rubbing at A0. So we were able to release it at A0. So it happens.
You could do it endoscopically, correct?
Easy, yes.
Yeah. Okay. You just keep going.
Easy peasy.
Right?
Yeah.
Yeah.
You just keep going, and you can see it.
Yeah, you could
So
definitely see it.
Feel it.
Endoscopically, and you can feel it. Yeah.
So typically, if you're doing a palmar incision and the patients are triggering at the A2 pulley, you have to make another incision to
Right.
take a slip of the FDS tendon. So this way, you only have to make one incision no matter what.
2 birds, 1 stone. I love it. I
Yes,
love it. It's great.
exactly. Yeah.
It's great.
So
Ah,
there's a lot of
fascinating.
benefits to that incision, aside from the, just being able to look at the A2 pulley and not violating the palmar fascia.
All right, great. I mean, it's just it's a very, very cool procedure. And do you do it on the other fingers as well?
Which other fingers do you have in mind?
Endoscopic. So what I mean is, for people who don't really know this, like, everybody assumes it's going to be your ring finger, but do you do the index finger and the pinky and all that stuff?
I am a non-denominational endoscopic trigger finger release. I will do it on any finger.
You know,
All
I
the
set it
fingers
up and you knocked it down, Doc. Good job.
Oh yeah. All the fingers are the same to me. Serious, okay?
Yes.
Okay.
Yeah.
As long not the thumb, but the fingers. You know,
The
they have-
thumb's the exception.
in the French language, they have names for fingers that are a little more elegant than what we call them. So, like, you've got the thumb, which is the pouce, and then you've got the index, and then the third finger is mejev, and the fourth is annular, and then the fifth one is auricular.
Auricular.
Yeah, because you stick your finger to clean your ear with
That's funny.
in your ear, auricular. Yeah.
All
So,
right.
and in hand surgical terms, like we never, like in my training, I once, when I first started my fellowship, I was at the hospital for special surgery, and I made the mistake of going, "Oh, that patient's pinky's triggering," and hand surgeons don't call it the pinky.
No.
No. That's what you call it when you're in nursery school. But
Hey, you're making
like-
fun of me.
yeah, when you go one little,
The pinky.
yeah, so, yeah, one
Fourth or
little
fifth.
piggy.
Is
two
it the
little
fourth or the
piggy,
fifth?
three
The fourth or
little-
the fifth?
So when you call it the pinky, it was quite embarrassing. And I go, real doctors, surgeons don't call it the pinky. It's
Did
the
they say
fifth
that to you?
digit.
They really
Oh,
said
yeah.
that to you? Oh my goodness.
Oh yeah, that's serious stuff.
Wow.
Yeah,
Yeah, I
it's
was
almost it's insulting.
The last time I was at what is it? HSS, Hospital of Special Surgery. I was training this doctor, and he was from Britain. I said, "Oh, I went to university in Britain," but I said college, and he was like, "What?" He's like, "Romi, you went to university. You didn't go to college." I was like, "Oh, sorry." So from then on, I've always said I've gone to university, and JP makes fun of me all the time because he's like, "You went to university?" Because it's so British.
Pinky's got to be up to say that.
With the university.
I went to university. Yeah.
With the pinky up.
Yeah, you gotta have the pinky out. Yeah, it's pretty
Got
funny.
it.
Yeah, and if you want the slang, it's uni.
Yeah.
Romi,
Yeah.
go to uni. Yeah. Yeah. So.
Yeah.
All right.
So
All right. So we're gonna wrap this up, Dr. Kulber.
All fingers, yes. It's non-denominational. You can do all fingers. Less scarring. Really great operation. I don't know why not everyone does it this way, because it's really you don't have to worry about it. Patients don't really have to go for therapy as much as I used to have to send them when you make an incision in their palm. Very similar to endoscopic carpal tunnel.
Very.
And but a real hassle, and has more benefits because you have access to the A2 pulley system, which you don't when you're making it in the palm.
Right.
So I think it's a good game changer. Well done. Yeah,
I agree. Oh, thank you.
great.
It was a team effort. Team effort.
It's collaboration. That's what it's all about.
That's what it's all about. And like we said in the last podcast, we're always standing on the shoulders of giants. So we really are. We really are. There's so many.
Fibonacci and Dr. Littler.
Yeah, there you go. One day they'll be saying it about you. Don't worry. They're like, yeah, Dr. Kulber came up with that. All right, we got to run. I want to thank you so much for your time, and everybody, please, like, subscribe, do all that stuff, click through, and watch our podcast on YouTube. It's called Endotopic. Thank you so much for your time, Dr. Kulber, and have a great night.
Great being here. Bye-bye.